Dr. David Ahlborn is a board-certified urologist with specialized training in robotic surgery and urologic oncology. He completed his fellowship at Hartford Hospital in 2021 after finishing his urology residency and general surgery internship at Mount Sinai Hospital. He earned his medical degree from Columbia University College of Physicians and Surgeons in 2015 and holds a Bachelor of Arts from Harvard University. He also became board certified by the American Board of Urology in 2023. His practice focuses heavily on urologic oncology, primarily treating cancers and tumors of the prostate, kidney, bladder, and testes. Additionally, he manages benign prostatic hyperplasia, BPH, using a range of treatments from medications to minimally invasive surgeries. Welcome, Dr. Ahlborn.
Thank you. Thanks for having me. So, thanks for that wonderful introduction. As you said, I'm primarily a urologic oncologist, meaning I do mostly cancer work, but I'm well-versed in general urology as well, and it makes up a significant portion of my practice. And so today, I wanted to talk about a topic that is extremely common, and hopefully I'll be able to answer some of your questions. And at the end of this, you'll have a better understanding of, what causes these sort of things and how we can avoid them. I have no disclosures. So, UTIs versus overactive bladder. Like I said, UTIs are a very common finding in the population. 50% of women and 12% of men will experience a UTI at some point in their life. But overactive bladder is not the same thing as a UTI. They each have very specific definitions, and it's up to the clinician to find out what is going on and tips so that we can accurately treat you. So a UTI is a group of symptoms that are localized to the urinary tract, and they are usually combined with inflammation and bacteria. And that's an important part, that for it to be a urinary tract infection, there has to be a bacterial source, because the symptoms that go along with UTIs, such as burning with urination, or urinary frequency, or urinary urgency, those symptoms can be seen in other processes as well, including overactive bladder. Other symptoms like foul-smelling urine and blood in your urine could be indicative of different problems like malignancies or something like that. So having a bacterial source is an important part of a urinary tract infection. All right, so what are the risk factors for urinary tract infections? Like most health issues, diabetes and obesity are significant risk factors for urinary tract infections. Are some rare diseases like sickle cell anemia and neurologic disorders. Anytime there is a foreign body or something that's not supposed to be in the urinary tract, like kidney stones or indwelling hardware, like a Foley catheter or tubes or stents, could be slings, anything that's not supposed to be in there has the potential for harboring bacteria and can also cause these infections. Other issues such as sexual activity and other things related to sexual activity like spermicide or diaphragm use put people at risk as well, as does the age at which you have your first UTI and whether or not you have a family history of UTI. And lastly, menopause. Changes in estrogen levels can also change the balance of your flora and put you at risk of infections. We'll talk about that a little bit as well. So how do we work this up? Well, the evaluation of symptoms with your doctor is important. Like I said, a history can lead you down a path towards one diagnosis or the other, and getting details about how long your symptoms have lasted, how severe they are, and what the character of your symptoms are is important in that. We also use lab tools like a urinalysis or a urine culture. There's two ways of doing urinalysis, either in your office, your physician's office, or in the lab. And The test that we run in the office is a screening test. There's lots of false positive and false negatives. So ideally, once you have a urine specimen in the office, you'd like to send it out to a lab where more specific testing and more sensitive testing can be performed. Urine cultures are a very important part of the UTI diagnosis, and that's because we need to show that there's bacterial growth. Once we have that bacterial growth, we're able to find out which antibiotics are designed to kill that specific bacteria. So the treatment of UTI is based primarily in two ways. One is bacterial control, and the other is symptom control. Like I said before, we use antibiotics to treat urinary tract infections. And we can start antibiotics empirically or at the first sign of symptoms in order to expedite the resolution of symptoms. But this is often using a broad spectrum antibiotic and can lead to more prolonged courses if we breed out resistant to specific bacteria. The more desired approach is to obtain a urine culture prior to starting antibiotics so we can identify the exact species and what it's sensitive to. For symptom control, we encourage hydration with about 1.5 liters per day. That's about 6 cups. Also cranberry supplements, which you can get over the counter, probiotics, and other over-the-counter pain meds such as acetaminophen or NSAIDs like ibuprofen, Motrin, Advil, things like this, or azo. There are also prescription medications that can help with discomfort, namely phenazopyridine, which is the same active molecule in azo. So what about recurrent urinary tract infections? That has a very specific definition as well. That is if you have 2 or more UTIs in 6 months or 3 or more UTIs in 12 months. And the urine culture becomes an increasingly more important component of recurrent urinary tract infections because there are multiple ways you can present with recurrence. You can either have the same bacteria that is sensitive to the same antibiotics that is just not being cleared, which would suggest that there is an ongoing reservoir of that bacteria somewhere in the system, perhaps a kidney stone or something like that. And there's also recurrence with bacteria that's different than you had previously. And that would suggest that there's a different source every time for the bacteria. When there's recurrence of urinary tract infections, sometimes we evaluate this with more invasive tests or imaging studies like ultrasounds or CAT scans. We can also do things like urodynamics, where we put catheters and sensors in your bladder and on your pelvis to get a sense of how well your bladder is actually functioning. And then there's slightly more invasive procedures like a cystoscopy, where we would look in the bladder with a small camera to make sure there's no tumors. Occasionally, if we can't reduce infections down to a good standard of quality of life, we can give out prophylactic antibiotics either on a daily basis or surrounding certain events that might trigger your infections. And then there's menopause. This is a very common syndrome that happens in menopause called genitourinary syndrome of menopause. In essence, what happens is your estrogen falls, the vaginal tissue loses its fullness, and the urethra narrows. This leads to alterations in the urologic bacterial flora that is healthy and keeps away the infectious bacteria, and changes in the vaginal pH. Additionally, because there's thinning of the vaginal tissue, it's easier for bacteria to cross in and cause inflammation. For GSM, we have lots of treatment options. You can start with an over-the-counter vaginal lubricant, and they do have some procedures that are not exactly FDA approved. Frequently, what will be required is hormonal replacement therapy, and this is done in a number of ways. Either topical vaginal estrogen cream, which is the typical starting point, or topical androgens, or systemic hormonal replacement therapy. Now, there's a lot of controversy as to whether or not these agents are safe or propagate or can promote cancer. And we've done lots of research, and there is a very small link with cancers like uterine cancer if you use certain agents that are not compounded with other hormones. But in general, these drugs are very safe to use. So remember this slide with the description of UTIs? Well, let's talk about overactive bladder. So overactive bladder is a syndrome of symptoms dominated by urinary urgency. That's the sudden urge to urinate without the ability to defer it. And this commonly comes with things like urinary frequency, waking up at night, incontinence or leakage of urine, and it's always in the absence of a urinary tract infection, which can be hard to parse out because a lot of the symptoms are very similar. The risk factors for overactive bladder would be things like an enlarged prostate or BPH, recurrent infections, cancer or tumors of the bladder, kidney stones, pelvic floor muscle dysfunction, diabetes, drinking excessive fluids, and other neurologic disorders. We have a lot of treatments for this, but because it's not a disease like an infection, these types of treatments usually require persistence. It's not the type of thing that we give a 1-week course of a medication and then the symptoms are all gone. So the first step is behavioral modification. It's trying to identify what is going on in your diet and your routines that could be predisposing you to overactive bladder. And the first thing that we look at is fluid management. And that's both water, volume of water, but other types of liquids or bladder irritants. Anything caffeinated, alcohol, spicy food, hot sauce, anything that's sugary, so soda. And I know some of these things are they make life interesting and fun, but they also have consequences. So trying to identify what it is that's causing your symptoms can help you to reduce your symptoms. Bladder training is an important technique that we teach people in order to who have overactive bladder to help them get through urges and prevent things like incontinence so we can get them to the bathroom. These sorts of things are like a stop and stay still technique, where when you feel your urge, you try to quiet yourself and stay still while the urge passes. This can be complemented by squeezing your pelvic floor muscles 3 to 5 times quickly in order to defer the urge. This can take some concentration. And ultimately, the goal is to wait until the urge goes away so that you can slowly walk to the bathroom. There's a lot of good resources out there. And if you Google this link with improved bladder problems, there's a very good handout about the natural peaks and troughs of urinary urges and the various ways that we can control this. For very advanced overactive bladder, we have a whole department of people and physical therapists whose job it is to work with you on these educational methods for how we can defer urges. It also is an opportunity for us to do pelvic floor monitoring, muscle overactivity monitoring. If behavioral modifications have not worked, we have medications. And there's typically two categories of medications that we look to. And as I said before, these are not the type of medications that you take for 1 or 2 weeks and then your symptoms are resolved. Typically, when patients start on these medications, they're on them for a long period of time. The two main categories of medications are anticholinergics and beta-3 agonists. And you may have heard of some of these. These are the generic names, and they have brand names like Ditropan, myrbetriq, and things like this. Um, and they have some main differences, and particularly how they work and what their side effects are. The main side effects of the anticholinergics are dry mouth, dizziness, constipation, fatigue, nausea, urinary problems like retention, and potentially cognitive declines. Now, these medications are older, which is why they have more side effects, and also why this new category, the beta 3 agonists, were created. They have significantly less side effects, and the main reported side effects are hypertension, typically in people who are already on 3 or more antihypertensives. The question you may be asking is, why would anyone use an anticholinergic medication? The answer is, it really depends on what your plan will allow for. If you have questions about which medication might be right for you, you should refer to your urologist. Once we've exhausted medications as the potential cure for your overactive bladder, there are procedures. That would be something like bladder Botox, which can be done either in the office or in the operating room through a procedure where we put a camera in the bladder and inject Botox into the bladder. There are slightly more invasive procedures like nerve stimulation, where we would implant a little sensor into a nerve where it would stimulate to reduce the urges. And lastly, there are very invasive procedures, something called a bladder augmentation, where we increase the capacity of your bladder so that it can hold on to more urine before you feel these urges. Ultimately, because overactive bladder is a syndrome, the goal is to improve your quality of life. Everything that we do, medication-wise, may have a side effect, and complete elimination of the need to urinate is not realistic. You have to urinate, so it's a matter of finding the balance between when you're comfortable with your urination. So with that, I am going to open up the floor to some questions, and I can go back to some slides if there are specific questions about specific things.
Great. I'd like to remind everyone that you can submit your questions in the Q&A button at the bottom of your screen. Our first question is, should all patients with recurrent UTI be referred to urology, or can they be appropriately managed in primary care?
It's a good question. It's important to work up why somebody is getting recurrent urinary tract infections, because the list of things that can be contributing to it is long, and some of those things can be dangerous, like cancer. Now, depending on your primary care physician's comfort level, they can do basic things like obtain an ultrasound or make sure that you get a urinalysis without in periods of times when you don't have an infection, to rule out things like blood under the microscope, which it would be a potential indicator that something more dangerous is going on. Ultimately, if there's any concern that the infections are not being well managed with basic principles like hydration and cranberry supplements, a referral to a urologist is a good idea. Things like simple UTIs, like a single UTI, doesn't need to be referred to a urologist. In fact, many people will treat a simple UTI empirically without a urine culture. And that's fine, because like I said before, you get symptom relief a lot faster when you take antibiotics. The antibiotics work, within 6 to 12 hours. It kills all the bacteria within 6 to 12 hours. But because there's this significant inflammatory response, it takes time for you to feel that relief.
Okay, there was a link that you showed. Can you state or show the link again?
Hold on, I didn't catch that. My speaker has gone out. So I want to do, can you repeat the question?
Sure. There was a link that you showed, but it went by too quickly. Can you show it
Oh,
again?
yes. Yes. So this organization is a urologic organization designed specifically to help people with bladder issues like overactive bladder and infection. So that's this SUFU org.com. If you Google with improved bladder problems, you can get to like a PDF. That's really good. But even here, this sufuorg.com/OAB would be a really good resource for people to start on.
Okay, there was also a request to go back to the slide that pertains to menopausal causes for urinary problems.
My headset is. I'm like really struggling to. I did not get the question.
So,
Let me try to change something here.
okay.
I think the batteries are just dying on this headset. 1 second. Okay, try again.
Okay, there was also a request to go back to the slide that pertains to menopausal causes for urinary problems.
Let's see. Is this the slide or is this a better slide? This is starting to get a little bit biologic-y, with how like changes in the pH, can affect overall tissue and bacterial penetration.
I wasn't sure if I had that on. Was I on mute?
Yeah.
Is Hitrin one of the recommended medications?
So Hitrin is a medication that treats lower urinary tract symptoms. So one of the um, one of the risk factors for OAB is lower urinary tract symptoms. And that's typically a term used to describe BPH or enlarged prostate for men, where the prostate is enlarged, and the prostate is basically a cork that is designed to keep urine inside of you. But sometimes, and particularly as you get older, that cork works too well. And then your bladder, which is a muscle, has to squeeze and work harder and harder and harder to get the urine out of the prostate. And that in turn causes changes in the way the bladder works and how sensitive it is to bladder irritants like caffeine and like sugar and like alcohol. So if we can improve the lower urinary tract symptoms with things like Hitrin or tamsulosin or Flomax or alfuzosin or any of these things, then we can help to retrain the bladder to not be so irritated by some of these things. Train it to hold on to urine a little bit more comfortably because it doesn't have to work as hard to get the urine out. So that's a good question too.
Okay. Are anticholinergic drugs associated with an increased risk of dementia?
That's another good question. I don't know that the correlation is so strong to say that anticholinergics cause dementia, but we don't like to use it in people who have neurologic disorders or who already have signs of dementia because we do see that it worsens those conditions. So long-term usage should be monitored very closely. And usage in people who have neurologic disorders, should be used with extreme caution.
Okay. Should I be drinking cranberry juice as a preventative measure?
You can drink cranberry juice does reduce your risk of infection, but you have to be careful because a lot of these juices have a significant amount of sugar in them. And it's really counteractive to what you're trying to accomplish. So it's probably better to get a cranberry supplement, which you can get at Whole Foods or CVS. There's actually one well-studied um, medication called Allura, which has been clinically proven to reduce the risk of infection. So while you may benefit some from a cranberry juice, you have to be careful with how much sugar it is, particularly added sugar. And if you want the maximal effect, you should consider a cranberry supplement.
If one has an urge to go to the bathroom and cannot make it to the bathroom, besides squeezing, what else can someone do? Does the Kegel exercises work?
It's another good question. So um, there's a lot of different techniques, physical and it's more mental, that can work to help you defer that sort of incontinence. Um, Kegel exercises are kind of the basic pelvic floor muscle exercise to strengthen the pelvic floor. But you want to be practicing Kegel exercises when you're not urinating, because if you practice Kegel exercises when you're supposed to be urinating, you can actually create dysfunctional voiding where your bladder doesn't know if it should be squeezing or if it should be relaxing. So the optimal time to practice Kegel exercises is when you're not urinating. So breakfast, lunch, and dinner, 3 times a day. And what you do is you try to contract the muscle that would normally be used to stop the flow of urine. So you can practice to get a sense of what muscle you should be contracting while you're urinating, just to find out what is the muscle, what is the mechanism that I should be trying to emulate, and then repeating that mechanism at times when you're not urinating. And if you can do it 3 times a day, 10 times each time, then that would be a good way to strengthen the pelvic floor muscle. But there's a balance because you don't want to over tighten those muscles. In certain circumstances, you can, cause dysfunctional voiding. And that's where the pelvic floor physical therapist is really a valuable resource because they're able to monitor muscle tone and sphincter tone and say, maybe the issue isn't that it's not that it's strong enough, but it's actually that these are over exercised and overstimulated. So I really, I really like this pelvic floor muscle therapy program that's in Mawa. They do a phenomenal job, and people see absolutely real benefit from physical therapy.
Actually, to give a plug for them, we have a video about the pelvic floor program on Tune Into Health on the Valley website. Okay, our next questions. I like this question a lot. Do male urologists typically see female patients and vice versa?
The short answer is yes. Urologists are trained to see both male and female, regardless of their gender. what can happen sometimes is as people get more advanced in their career, they specialize in different areas. So some people, there's a whole division of urology that's specifically designed for voiding dysfunction. And that's part of the organization, that the SUFU organization that I was alluding to before. These are people who are fellowship trained in dealing with the nuances of these sorts of things. But a lot of the things that I mentioned, the more invasive procedures like nerve stimulation and bladder augmentation, those things are pretty rare. And if you're getting to the point where that's being talked about, then your urologist should probably refer you to one of those specialists. Uh, as a general trend in the field, there are more male urologists than female urologists. So, you know, you're more likely to see a male with one of these issues if you're a female and have overactive bladder.
Okay, if one gets a UTI while traveling abroad and therefore does not have access to her doctor and to a prescribed antibiotic, what can one do?
So this sounds like a question from somebody who has recurrent urinary tract infections because uh, it's, while infections are common, like 50% of women will get an infection, any single isolated event, like once a year, is pretty rare. So if you know that you're predisposed to getting infections, and travel could be one of the triggers because you're flying on airplanes or on a bus, which means you don't have very good access to liquids like water or to a bathroom. It's a new environment. Your diet is changing. So if this is one of your triggers, then it's important to talk to your doctor about perhaps having a prophylactic prescription of antibiotics so that when you're traveling, particularly abroad, you don't have to worry about going to an emergency room there or an urgent care center. Because getting a prescription, American doctors, they can't prescribe abroad. So if you call your doctor in the United States, he won't be able to send you a prescription there. You'd have to find somebody in that country. And then the other recommendations of staying hydrated and trying the cranberry supplement, they all hold true as well. And those things don't require a prescription.
Um, the menopause slide that you showed early on, that was for UTI, correct? Um,
So
can,
it's a syndrome called genitourinary syndrome of menopause, of which urinary tract infections are one symptom. So this is UTIs don't cause this. This is more a syndrome, kind of like overactive bladder is a syndrome. This is a syndrome only in women who have undergone menopause where their estrogen level is low. That syndrome has other symptoms like painful sexual intercourse, vaginal dryness, suprapubic pain, so like pain just above your pubic bone, or urinary frequency. And you know these can be really debilitating symptoms.
so is urinary leakage considered part of that syndrome, or would that be?
It can be. It can absolutely be part of this syndrome. But urinary leakage should it there your physician should try to identify the cause of urinary leakage because there's many different types of urinary leakage. In two broad categories, there's stress incontinence and there's urge incontinence. So one of the components of overactive bladder is this urinary incontinence or urge urinary incontinence. And that's if you feel the urge to urinate and you can't defer that urge, that you will leak urine into your underwear or whatever. The other component of incontinence is stress urinary incontinence. And that's when if you cough or sneeze, then you get leakage of urination. And The Kegel exercises that was mentioned earlier, that is more a treatment option for stress urinary incontinence because the problem isn't so much that the bladder is too sensitive to something, but that the pelvic floor is just too weak to resist the rise in pressure that comes when you exercise or sneeze or laugh or something like that. Um, Stress urinary incontinence, that's a kind of different disease pathology for which we don't have a lot of good medications. That is usually pelvic floor muscle therapy, Kegel exercises, or something like a sling or a sphincter or something like that. And you can have the two concurrently. You can have stress incontinence and urge urinary incontinence. And then it's a matter of trying to identify which is most bothersome, which is the first to try to treat. We know that treating stress incontinence with something like a sling or a piece of like a tape can worsen urge incontinence. So it's important, to talk with your doctor and for your doctor to really parse out what your symptoms are so that they can narrow down what the right treatment for you is.
Okay, there was also a request for the name of the pelvic floor practice that you mentioned. I didn't know if it was on that slide. If not, I can look it up on the website and type it in.
Yeah, it's I would Google this physical medicine rehabilitation services in the Valley um, on the Valley website. The pelvic floor department is primarily in Mawa, but I'm not sure that they have a specific name. I just know it as the rehabilitation service.
I'll look that up while you're answering questions and put it in the chat. Okay, we're encouraged to drink plentiful liquids to stay hydrated, but that conflicts with having an overactive bladder. Any suggestions?
So you want to be drinking enough water so that you're not thirsty throughout the day. And if you have an infection, then you should ideally be drinking 6 cups of water. If you're drinking 8, 10 cups of water and you have these symptoms, you might consider reducing the amount of water that you're drinking. Additionally, water in and of itself may make you pee more frequently just because of the volume, but it really should not contribute to urgency, which is what overactive bladder is. Urgency comes more from I'm going to call them toxins, but they're really just, what is in the drinks that we're drinking, the alcohol, the coffee, the tea, the soda, the juice. It's all those other things like caffeine, alcohol, sugar that are processed by your kidneys, concentrated, and then sit in your bladder and irritate the muscles. Water doesn't have any of those components. So even though it's filling more quickly, the musculature and the nerves in the bladder aren't being so irritated by another molecule. So yes, it's important to stay hydrated, particularly if you have, things like you're prone to kidney stones or, um, if you have, some kidney dysfunction. But you should really talk to your doctor about what the right amount of water is for you. Because sometimes if people with cardiac issues or heart issues, too much water can be bad for them. Too much water and salt could be bad for them. So you should really talk to your physician about what the right amount of fluids is for you.
Is seltzer water okay as water?
Seltzer water has been linked with recurrent urinary tract infections, but it's not as bad as if you are adding like sugary extracts or flavors to it. So you might want to be careful if you're drinking in excess of seltzer water and you're finding that you're getting recurrent infections. That might be a place to start and target.
Okay. Does regular coffee or decaf coffee make a difference?
Decaf is going to be better than regular coffee because it's really the caffeine that's
that's affecting your bladder the most. But many people put sugar and cream and other things that we don't even think about. They add that to their coffee, which contribute to the irritants. So even if you drink decaf coffee, you may still be having overactive bladder because of the other things you're putting in it.
Okay. You mentioned, sorry.
I lost you there for a second. I think you're muted again.
You had mentioned earlier in the slides that diabetes and obesity were causes of many things. But if someone were to get under a healthy BMI and get their sugar under control, would that in theory control the problems that they would have related to overactive bladder or UTI?
Absolutely. This is obesity and diabetes are well linked with these two problems. And it's for a number of reasons. Um, the problem with diabetes is your tissue has a much higher level of sugar, and bacteria, that is the food for the bacteria. Additionally, can put you at an increased risk of immunocompromise. Like your immune response in the diabetic state is not as good as in the non-diabetic state. So there's two sort of problems with diabetes. Additionally, if you're in the very diabetic state, then you could be putting sugar directly into your urine, which would further, provide food for the bacteria. There are some um, diabetic medications who, by design, pull sugar into your urine, and so it might be worth considering changing medications if that's what you're finding. Trying to lower your A1C by things like diet and exercise is a preferable way to do it, but that's not an easy thing to accomplish. There are some people based on their genetics who would just have a harder time controlling their A1C. Um, in terms of obesity, we know that the pressure on your body is higher because of the extra mass that you're carrying around. This, in addition to the areas that we're talking about, which are naturally filled with bacteria, are at an even higher bacterial load because the tissue is closer to itself. So losing weight and controlling diabetes will absolutely improve your symptoms. In fact, losing weight may resolve your overactive bladder at all. That's probably because if you're losing weight, you're probably dieting to some extent as well, cutting out some of those bladder irritants. So the loss of weight and the control of your diet is a double improvement in your symptoms.
Great. And I think that's all our questions this evening. Thank you so much, Dr. David Ahlborn, for your informative presentation this evening. At this time, I'd like to remind